Okay, so neurology second video. Epilepsy. Epilepsy is more likely to occur in young children or people over the age of 65 years. However, it can occur at any time. Epilepsy is usually controlled but not cured with medication, although surgery may be considered in difficult cases. More than 30% of people with epilepsy do not have seizure control even with the best available medications. Not all epilepsy syndromes are lifelong. Some forms are confined to childhood. Epilepsy should not be understood as a single disorder, but rather as syndromic with vastly divergent symptoms, but all involving episodic abnormal electrical activity in the brain. So, nice April 2018. Valproate must not be used in girls and women, including in young girls below the age of puberty, unless alternative treatments are not suitable and unless the conditions of the pregnancy prevention program are met. So, no Valproate for girls. Basics: two main categories, generalized and partial seizures, and partial seizures may progress to general seizures. Other types can be myoclonic, atypical, atonic, and tonic seizures are usually seen in childhood. Okay, and generalized, no focal features, consciousness lost immediately. So generalized can be divided into grand mal, tonic-clonic, petit mal, absent seizure, and partial seizure progressing to generalized seizure, and partial focal seizure depending on the location, simple or complex, no disturbance of consciousness or awareness. That's simple, and complex is consciousness is disturbed, so it's focal depending on the location. And temporal lobe can have aura or deja vu or jamais vu or motor Jacksonian features. Myoclonic can occur in a variety of conditions. Okay, that's a tip. Complex partial seizures can take the form of automatism, such as chewing and swallowing, repeatedly scratching the head or searching for an object. Some people may even undress. They can occur as a result of seizure activity in any part of the brain, but most commonly arise in the temporal lobes. Important thing. Okay. For treatment, first thing that comes is monotherapy should be attempted before combination therapy is started. And caution should be exercised when combining sodium valproate and lamotrigine, as severe skin rashes such as Stevens-Johnson syndrome may be provoked if together they are given. Most neurologists now start antiepileptics following a second epileptic seizure. NICE guidelines suggest starting antiepileptic after the first seizure if. So you can start from the first seizure if the patient has a neurological deficit already. Brain imaging shows a structural abnormality. The EEG shows unequivocal epileptic activity, or the patient or the family or carers consider the risk of having a further seizure unacceptable. Okay, so first line will be sodium valproate, as we all know. Sodium valproate is first line for generalized seizures. Carbamazepine for partial. So carbamazepine is first line for partial seizures. So here are the four classes of seizures, and first one is tonic-clonic. Tonic-clonic first line is sodium valproate. Second line can be lamotrigine or carbamazepine. Adjunct therapy can be clobazam, lamotrigine, levetiracetam, sodium valproate, or topiramate. Okay. Absence seizure, petit mal seizure. First one is ethosuximide or sodium valproate, children. Second line is lamotrigine. Sodium valproate particularly effective if coexistent tonic-clonic seizure in primary generalized epilepsy. Don't offer carbamazepine, gabapentin, oxcarbazepine, phenytoin, or pregabalin, or all these things. Should not offer. Makes it worse. So next is myoclonic seizure, and first line is sodium valproate, and second line levetiracetam or topiramate. Lamotrigine can actually exacerbate myoclonic seizure, so very important. Don't give lamotrigine here. Okay. Also, don't offer carbamazepine, gabapentin, oxcarbazepine, phenytoin, pregabalin, tiagabine, vigabatrin. And partial focal seizure, first line carbamazepine or lamotrigine. Second line is levetiracetam, oxcarbazepine, or sodium valproate. Adjunct therapy, carbamazepine, clobazam, all these things can be used. Okay. Absence seizure, polymal are a form of generalized epilepsy that is mostly seen in children. The typical age of onset is 3 to 10-year-old, and the girls are affected twice as much as boys. Okay, so next is vigabatrin, rarely used anti-epileptic. For the 40% of the patients develop visual field defect, and which may be irreversible. Visual fields should be checked every 6 months. We are using this. Uh, should be checked every 6 months. And the features can be absence, last a few seconds, and which one is this? This one is absence seizures. I think absences last a few seconds and are associated with a quick recovery. Seizures may be provoked by hyperventilation or stress as well. The child is usually unaware of the seizure. They may occur many times a day. EEG will show bilateral symmetrical 3 Hz pattern. Group prognosis 90-95% become seizure free in adolescents. So, like most of them become seizure free. Anti-epileptic drug cessation can be considered if seizure free for more than 2 years. Stop AED over 2-3 months. Okay. In a patient who has been seizure free for more than 2 years, the chance of recurrence in the next 2 years is to 43% if they stop therapy, compared with 10% if the drugs are continued. So it's better to continue for a while. Factors that have been shown to increase the risk of seizures include older age, use of multiple anticonvulsants, history of myoclonic or tonic-clonic seizure, previous abnormal imaging or EEG, seizure while on therapy, the risk of uncontrolled epilepsy during pregnancy. During pregnancy generally outweigh the risk of medication to the fetus. All women thinking about becoming pregnant should be advised to take folic acid 5 mg per day well before pregnancy to minimize the risk of neurological defects. And 1 to 2% of newborns to the non-epileptic mothers have congenital defect. This rises to 3 to 4% if the patient takes anti-epileptic medication. Other points: aim for monotherapy. There is no indication to monitor anti-epileptic drug levels routinely. Sodium valproate associated with neural tube defects. Phenytoin associated with cleft palate. Lamotrigine suggests that the rate of congenital malformation may be low. The dose of lamotrigine may need to be increased in pregnancy. Carbamazepine, often considered the least teratogenic of the older anti-epileptics. Breastfeeding is generally safe for mothers taking anti-epileptics except for the barbiturates. Okay. So it's advised that the pregnant woman taking phenytoin are given vitamin K in the last month of pregnancy to prevent clotting disorder of the newborn. Okay. Infantile spasm, West syndrome, occurs between 3 to 12 months of age, managed by vigabatrin. A side effect causes alopecia, decreases visual acuity, diplopia, or steroids. West syndrome is a triad of infantile spasm, a pathognomonic EEG pattern called hypsarrhythmia, and metal retardation, although the international definition requires only 2 of the 3 elements. Okay, there's a way to find out if it's seizure or syncope. You just have to differentiate. Immediate precipitating factors, usually none, and syncope, there will be something happening before the episode, like emotional stress, balls of orthostatic hypotension, or cardiac etiologies. Premonitory symptoms can be none or aura, tiredness for syncope, tiredness, nausea, diaphoresis, turning of vision. Posture at onset variable and is usually erect for syncope. Transition to unconsciousness is often immediate, and this one is gradual over seconds. Duration of unconsciousness minutes and seconds for syncope. Duration of tonic or clonic seizure movements 30 to 60 seconds, and syncope never more than 15 seconds. Facial appearance during event, cyanosis or frothing at mouth. Syncope is pallor. Disorientation and sleepiness after event, many minutes to hours and less than 5 minutes for syncope. Aching of muscle driven often and sometimes. Biting of tongue sometimes, rarely. Incontinence sometimes, headache sometimes, rarely. So we really need to differentiate the two. Okay, functional seizures, common and occur in 10-20% of patients referred to specialist epilepsy clinics with intractable seizures. The history of the attacks is usually suggestive, but it's not diagnostic of their functional nature. Non-epileptic attacks are broadly divided into hyperkinetic thrashing attacks and akinetic motionless attack. There are no clinical signs which never occur in epilepsy, although some are very rare and no signs are unique to epilepsy, apart from ictal electroencephalography. The strangeness of an attack should in itself not imply a diagnosis of non-epileptic attack. Okay, distinguish from epileptic seizure. How do you distinguish normal functional seizure from epileptic seizure? Asynchronous limb movements, undulating motor activity, purposeful movement, rhythmic pelvic movement, side to side head shaking, biting the tip of the tongue as opposed to the side. So all these things will make it functional seizure. Ictal crying, vocalization during tonic-clonic phase, closed eyelids, resistance to eyelid opening, lack of cyanosis, and rapid post-ictal reorientation. All these things will make sure that it's functional seizure. Prolactin is often raised 15 to 20 minutes after a tonic-clonic seizure and should be normal in non-epileptic attacks. But there are a number of problems. Serum rises are often seen in syncopal episodes. It may be normal, especially in partial epileptic seizure, and the test is often badly carried out in practice too early or too late. It's therefore generally not recommended outside the specialist center. Video telemetry is the golden standard investigation for possible functional seizures. And so in the video telemetry, you get to see if it's asynchronous limb movement, undulating motor activity, purposeful movement, rhythmic pelvic movement, side to side head shaking, biting the tip of the tongue, ictal crying, and all these things. Okay, next is upper motor and lower motor neuron signs, very important as well. Okay, so upper motor neuron, also known as pyramidal insufficiency, occurs in the neural pathway above the anterior horn of the spinal cord. So above the anterior horn is upper motor. Such lesions can arise as a result of stroke, multiple sclerosis, spinal cord injury, or other acquired brain injury. Symptoms can include muscle weakness, spasticity, decreased motor control, include muscle weakness, spasticity, and decreased motor control, including a loss of the ability to perform fine movements. Okay. Muscle weakness, spasticity, decreased motor control, including a loss of the ability to perform fine movements, increased reflex and clonus, and extensor plantar response known as Babinski's kind. And for lower motor neuron lesions, it causes muscle wasting, decreased strength, and decreased reflex, absent ankle jerk. In example, in affected areas, muscle atrophy with long-standing lesion, lower motor neuron is indicated by abnormal EMG potential spasticulations, paralysis. Bell's palsy, bulbar palsy, poliomyelitis, and ALS are all pathologies associated with lower motor neuron dysfunction. So Bell's palsy, bulbar, poliomyelitis, ALS, all of them are lower motor neuron problems. Okay. Causes of combined upper motor and both lower motor neuron can be subacute combined degeneration of the cord, is one of them. We have both of the features. Motor neuron disease, Friedreich's ataxia, syringomyelia, syringobulbia, taboparesis, syphilis, conus medullaris lesion. Okay, spastic paraparesis. It's like basically an upper motor neuron pattern of weakness in the lower limbs. What can be the reason for that? Paraparesis, like the legs. So demyelination, like multiple sclerosis, cord compression, trauma tumor, parasitical meningioma, tropical spastic paraparesis, hereditary spastic paraplegia, transverse myelitis like HIV, syringomyelia, osteoarthritis of cervical spine are all causes of spastic paraparesis. Okay, Oppenheim's sign is seen when the scratching of the inner side of the leg leads to extension of the toes. It's a sign of cerebral irritation, pyramidal. Upper motor neuron this is one of the Babinski-like response. So you just scratch the inner side of the leg, leads to the extension of the toes. Okay. Motor neuron disease is one of the differentials of both, like upper motor and lower motor together. So what happens here is a neurological condition of unknown cause which can present with both upper and lower motor neuron signs. It rarely presents before 40 years, and so this one shows both signs. And various patterns of disease are recognized, including ALS, PLS, progressive muscular atrophy, and bulbar palsy. In some patients, however, there is a combination of clinical problems. So these are the four different types of motor neuron disease. So ALS, amyotrophic lateral sclerosis, 50% of the MND. Typically lower motor neuron signs in arms and upper motor neuron signs in legs. So it's like the opposite. In familial cases, 5% of the case autosomal dominant. The gene responsible lies on the chromosome 21 and codes for superoxide dismutase. So it's totally like an like can familial cases 5%. And then comes PMA, progressive muscular atrophy. So this one has only lower motor neuron signs compared to primary lateral sclerosis, which is like upper motor neuron signs, lateral. So it's just opposite again. Lateral up should be L, lower motor, but lateral. And progressive muscular atrophy, lower motor neuron signs only, affects distal muscle before proximal, carries best prognosis. So this one is the best prognosis. And bulbar palsy is pulse of the tongue muscle of chewing, swallowing, and facial muscles due to loss of function of the brainstem motor nuclei, carries worse prognosis. Okay, so there are a number of clues which point towards the diagnosis of MND. So when the questions will come, it will have a lot of small clues which can help you find the diagnosis, like fasciculation. It's basically lower motor neuron, like for this one AL is lower motor neuron. So fasciculation is there, absence of sensory sign, but of course it has both upper and lower motor neuron the symptoms. Absence of sensory sign symptom. So this is one of the clues, biggest clue. Vague sensory symptoms may occur early in the disease, later, but never sensory signs. So there's no sensory sign. Lower motor neuron signs in arms and upper motor neuron signs in legs. Like what? Wasting of the small hand muscles. Tibialis anterior is common. Tibialis anterior function to stabilize the ankle as the foot hit the ground during the contact phase of walking, and acts later to pull the foot clear of the ground during the swing phase. It also functions to lock the ankle, as in toe kicking a ball when held in an isometric contraction. So, what is the management for this dangerous disease? Basically, riluzole, an anti-glutamate drug, and used mainly in ALS, prolongs life by only 3 months and is expensive as well. And so next would be respiratory care. Non-invasive ventilation, usually BiPAP, is used at night, and studies have shown a survival benefit of around 7 months. That's for BiPAP. And prognosis is 50% of patients will die within 3 years. The diagnosis of motor neuron disease is clinical, but nerve conduction studies will show normal motor conduction and can exclude neuropathy. Electromyography shows a decrease in number of action potential with increased amplitude. MRI is usually performed to exclude the differential diagnosis of cervical cord compression and myelopathy. You can do MRI, but usually the diagnosis is clinical. The other features are doesn't affect of motor neuron disease, doesn't affect external ocular muscles, no cerebral sign. So there's no cerebral sign. That's one of the clues. No ataxia. No external muscles, ocular muscles affected. Abdominal reflexes are usually preserved, and sphincter dysfunction is present as a alert feature. Stephen Hawking, of one of the most so this guy Stephen Hawking, he passed away with ALS. So next is essential tremor. It's also a very important topic. Essential tremor, often previously called benign essential tremor, usually affects both upper limbs. Essential tremor is an autosomal dominant condition that is made worse when arms are outstretched, and which made better by alcohol and propranolol. Features can be postural tremor, worse if arms outstretched, improved by alcohol and rest. Most common cause of titubation head tremor. Management is propranolol is first line. Primidone, anticonvulsant, is sometimes used when propranolol is contraindicated. Okay, chorea, as you know, the causes of chorea. So the causes of chorea can be Huntington's disease, Wilson disease, ataxia telangiectasia, and SLE, antiphospholipid syndrome, rheumatic fever, Sydenham's chorea, contraceptive pill, L-Topa antipsychotics, etc. Then the other ones are chorea gravidarum, thyrotoxicosis, polycythemia, rubra vera, carbon monoxide poisoning, neuroacanthocytosis, cerebrovascular disease. Okay, hemipalismus. It's a very rare movement disorder. It's a type of chorea caused by, in most cases, by a decrease in activity of the subthalamic nucleus. So hemipalismus subthalamic nucleus of the basal ganglia, resulting in the appearance of flailing, ballistic, undesired movements of the limbs. Features are ballistic movements, sudden involuntary jerking movements which occur contralateral to the side of the lesion, so it should be opposite to the side of the lesion. Primarily affect the proximal limb musculature, while the distal muscles may display more choreiform like movements. Symptoms may decrease during sleeping. Etiology: stroke in elders, infection or inflammatory in young. So stroke in elders and infection or inflammatory cause of the young people. And Anti-dopaminergic agents like haloperidol are the mainstay of treatment, and tetrabenazine may be considered when long-term therapy is required. So haloperidol is the mainstay of treatment. Tetrabenazine maybe. Okay, next is Tourette syndrome. And Tourette syndrome is a common neurodevelopmental disorder that begins in childhood or adolescence. Okay, so Tourette syndrome is a common neurodevelopmental disorder that begins in childhood or adolescence. It's characterized by multiple motor tics and at least one vocal phonic or tic. Common tics are blinking, winking, coughing, throat clearing, sniffling, and facial movements. Can sometimes be suppressed temporarily, and characteristically change in location, strength, and frequency. Tourette is at the more severe end of a spectrum of the disorders, of the tic disorders. So the last one is Tourette syndrome for tics, and head and eye tics can interfere with reading or lead to headaches, and forceful tics can lead to repetitive strain injury. No diagnostic test but MRI can be used to rule out the other causes. Behavioral therapies using habit reversal training and exposure and response prevention or first-line intervention in the management and have been shown to be effective. Typical and atypical neuroleptics are reserved for severe cases leading to complications. Facial nerve. Okay, facial nerve basically supplies face, ear, taste, and tear. Remember that face muscle of facial expression. Ear nerve to stapedius, taste is supplies the anterior two-thirds of the tongue, and tear is parasympathetic fibers to lacrimal glands. Also salivary glands. So all this you have to remember. Facial palsy and plus convergent squint. Lesion is in the pons where seventh is encircled by the eighth. So facial palsy and convergent squint. It means this. Okay, cause of facial nerve palsy. Bilateral facial palsy should be either sarcoidosis, GBS, or infections like polio or Lyme disease. Bilateral facial palsy, and unilateral facial palsy can be lower motor neuron like Bell's palsy, Ramsay-Hunt syndrome due to herpes zoster, acoustic neuroma, parotid tumors, multiple sclerosis, HIV, diabetes mellitus, and upper motor neuron stroke. Okay. So there's a difference between upper motor neuron and lower motor neuron. Of course, that upper motor neuron stroke spares the upper face. So if you remember SS, stroke spares upper face, forehead is spared. So the lower part of the face is affected, and lower motor neuron lesion affects all facial muscles. So all for lower motor neuron. All LL. Bell's palsy is an acute unilateral idiopathic facial nerve paralysis. The etiology is unknown, although the role of the herpes simplex virus has been investigated previously. Features: lower motor neuron facial palsy, forehead affected, so the full face is affected. Patients may also notice post-auricular pain, may precede paralysis. First comes this one. Precede paralysis, altered taste and dry eyes. Okay, so management can be according to September 2018 guidelines. Presentation with 72 hours of onset of symptom, prescribe prednisolone. So it's this thing. 50 mg daily for 10 days or 60 mg daily for 5 days, followed by a daily reduction in the dose of 10 mg for total treatment time for 10 days. Daily dose reduction, okay. If a reducing dose is preferred. Antiviral alone is not recommended, and antiviral plus steroid not really recommended, maybe of small benefit. So only steroid is the mainstay of treatment. That's what you have to remember. If untreated, 15% will have permanent moderate to severe weakness. And okay. Postcranial irradiation somnolence syndrome was first identified in patients treated with radiotherapy for scalp ringworm infection. Features can be excessive somnolence, so radiotherapy is the culprit here. Excessive somnolence, lethargy, and clumsiness tends to occur around 11 to 21 days or 31-35 days after high dose cranial radiotherapy. Um, no focal cause is identified, and it's postulated that the condition may occur due to post radiation demyelination. That's the main thing. No specific therapy is required. Some case reports suggest that corticosteroids may be of use, but the evidence is not firmly established. To differentiate it from cerebral metastasis or cerebral edema, there should be no new focal neurological signs in post-irradiation assess. The topic is headache and pain. So for cluster headache are more common in 5 men and smokers. Episodic eye pain, lacrimation, nasal stuffiness, occurring daily cluster headache. So pain typically occurs once or twice a day, each lasting 15 minutes to 2 hours, and cluster typically lasts 4 to 12 weeks. And intense pain around one eye, recurrent attacks always affect same side. Patient is restless during an attack, accompanied by redness, lacrimation, breath swelling, nasal stuffiness, meiosis and ptosis in a minority. Management: acute 100% oxygen, subcutaneous sumatriptan can be given. Subcutaneous sumatriptan. 5-HT1D receptor agonist, nasal lidocaine. Prophylaxis can be verapamil and prednisolone. So it's very important. Verapamil is prophylaxis. Consider a specialist referral. Some neurologists use the term trigeminal autonomic cephalgia to group a number of conditions, including cluster headache, paroxysmal hemicrania, and short-lived unilateral neurologiform headache with conjunctival injection and tearing. It's recommended that such patients are referred for specialist assessment, and as specific treatment may be required. For example, it's known paroxysmal hemicrania responsible to endomethacin. Okay. Chronic paroxysmal hemicrania, characterized by unilateral pain, which is generally oculofrontotemporal in location, can occur at any time, and patients often describe throbbing, boring, pulsating, or claw-like pain. Frequency of attack is usually 10 to 20 per day, and episodes usually last 2 to 25 minutes, but may also last up to 60 minutes. Patients may also complain of ipsilateral conjunctival injection, ptosis and lid swelling, lacrimation, rhinorrhea, so occasionally photophobia. The most effective treatment is with endomethacin. So this is for endomethacin. Okay, the most common differential diagnosis is from cluster headache, and most other important treatment is from cluster headache and other headache syndromes characterized by autonomic dysfunction such as SUNCT. Um, CH has male preponderance unlike CPH. Cluster headache has more male preponderance unlike CPH, which is more common in female hemicrania. In CPH, frequency of attacks is higher, especially usually more than 15 in 24 hours, whereas cluster headache has an attack frequency of 1 to 4, so CPH is higher frequency. The duration of headache is shorter in CPH, and in CH it's more. Duration is more in CH, cluster headache. Okay, migraine. Very important topic. The International Headache Society has produced the following diagnostic criteria for migraine without aura. At least 5 attacks fulfilling criteria B to D. That is headache attacks lasting 4 to 72 hours, untreated or unsuccessfully treated. Headache has at least 2 of the following characteristics: unilateral location, pulsating quality, varying with the heartbeat, and so unilateral location, pulsating quality, varying with heartbeat, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity like walking or climbing stairs. And then D, during headache, it is one of the following like nausea, vomiting, phonophobia. E, not contribute to another disorder. History and examination do not suggest a secondary headache, or if they do, it's ruled out by appropriate investigation, or headache attacks do not occur for the first time in close temporal relation to the other disorders. Okay, migraine with aura. Okay, in children, attacks may be shorter lasting. Headache is more common bilateral, and gastrointestinal distress is more prominent. Migraine with aura. Around 1 in 3 migraine patients tends to be easier to diagnose, with the typical aura being progressive in nature and may occur prior to headache. Typical aura includes a transient hemianopic disturbance or spreading scintillating scotoma, jagged crescent. Sensory symptoms may also occur. Common types of headache you can see here, diagrams given: sinus headache, cluster headache, tension headache, and migraine. So for migraine, the treatment, acute treatment often offer a combination therapy of oral triptan and NSAID or paracetamol. Oral sumatriptan is suitable for most people. Zometriptan and Neurotriptan, Lizatriptan, Electriptan, Almotriptan, and all these alternatives. So this one, triptan and NSAID or paracetamol. This is the one. If vomiting restricts oral treatment, consider non-oral formulations such as zometriptan nasal spray if there's vomiting with the oral one, or subcutaneous sumatriptan. If monotherapy is preferred, offer an oral triptan or NSAID or aspirin, 900 mg every 4 to 6 hours when necessary, up to 3 maximum of 4 gram daily. Consider adding an antiemetic such as metoclopramide, domperidone, or chlorpromazine, even in the absence of nausea and vomiting. Do not use ergots or opioid. Should not use an opioid for that. All patients receiving treatment with a triptan should be followed up where possible. Triptans are basically serotonin 5-HT1 agonist used in the acute migraines. So, 5-HT1 agonist, AG, acute AC. Epilepsy is not a contraindication to the use of triptans, so you can use it. Opioids are not recommended in the management of migraine. So prophylaxis should be given if migraines are causing frequent disability. For example, if there are 2 or more attacks per month that produce disability lasting for 3 days or more. Risk of medication overuse headache due to frequent use of acute drugs, and standard acute analgesia and triptans are either contraindicated or ineffective. Migraine is of an uncommon type, such as hemiplegic migraine. Migraine is of an uncommon type, such as hemiplegic migraine or migraine with prolonged aura. Consider referral or seek expert advice. The first line you can use for prophylaxis, can use topiramate or propranolol. You can use topiramate initially 25 mg at night for 1 week, then increase in steps at weekly interval. The usual dose is 50 to 100 daily in 2 divided dose, and then maximum dose is 200 mg daily. Advise women and girls of childbearing age. Potential the topiramate is associated with the fetal malformation and can impair the effectiveness of hormonal contraceptive. Propranolol, initially 80 mg daily, either twice a day or once, may be increased to 160 to 240. It's suitable for people with hypertension or anxiety, not suitable for asthma, COPD, peripheral vascular disease, or uncontrolled heart failure. If both are ineffective after 2 months of therapy at a target dose are unsuitable, offer a course of up to 10 sessions of acupuncture 5 to 8 weeks. So instead of that, you can give acupuncture. Riboflavin may be effective in reducing migraine frequency and intensity, so it's something new. Review the need for continuing migraine prevention 6 months after the start of the preventive treatment. Other prophylactic drugs are amitriptyline, pizotifen, used less commonly now due to adverse effects, weight gain, and drowsiness. Venlafaxine, sodium valproate, lisinopril, candicertan, losartan, and coenzyme Q10. Migraine during pregnancy, paracetamol 1 gram is first line, and aspirin 300 mg can be used, or ibuprofen can be used second line in the first and second trimester. So this one can be given in first and second trimester. Migraine and the combined oral concentrated pill. If patients have migraine with aura, then COC is absolutely contraindicated, as it can increase the chance of stroke. Migraine and menstruation. Many women find that the frequency and severity of migraines increase around the time of menstruation, and mefenamic acid is first line. Triptans are also recommended in acute situation. Hormonal contraceptives are useful if contraception is also desired. Do not offer combined contraceptive to women who have migraine with oral. Next is migraine and hormonal replacement therapy. Uh, this one safe to prescribe HRT for a patient with a history of migraine, but it may make migraines worse. Okay, next is trigeminal neuralgia. It's a pain syndrome characterized by severe unilateral pain. The vast majority of cases are idiopathic, but compression of the trigeminal roots by tumors or vascular problems may occur. The International Headache Society defines trigeminal neuralgia as unilateral, brief, electric shock-like pains, abrupt in onset and termination, limited to one or more division of the trigeminal nerve, bilateral in 3%, short-lived, lasting seconds to minutes and stops suddenly. Pain is commonly evoked by light touch, including washing, shaving, smoking, talking, and brushing the teeth. Trigger factors and frequently occurs spontaneously. Small areas in the nasolabial fold or chin may be particularly susceptible to the precipitation of pain. Trigger areas. Okay, episodic pain may go into remission for weeks or months before returning. Pain-free periods tend to gradually get shorter between episodes. Some people with trigeminal neuralgia might have autonomic features such as conjunctival injection, um, lacrimation, nasal congestion or rhinorrhea, eyelid edema, ptosis, or facial sweating. Management: if there are red flag symptoms and signs, admit or refer urgently for specialist assessment, like sensory changes, deafness, or other ear problems. So, this is like red flag symptoms. So, by the way, carbamazepine is the first line of treatment. Red flag symptoms can be sensory changes, deafness, a history of skin or lesion that could spread perineurally, pain only in the ophthalmic division, like eye socket, forehead, nose, and or bilaterally, optic neuritis, family history of multiple sclerosis, age of onset before 40 years. All these red flags. Okay, common topic in exam: neuropathic pain. May be defined as pain in which arises following damage or disruption of the nervous system. It's often difficult to treat and respond poorly to external analgesia. Examples include diabetic neuropathy, post-herpetic neuralgia, prolapsed intervertebral disc, um, trigeminal neuralgia, although it's a type of neuropathic pain but managed separately as above. Nice updated guidelines in 2019 follows the management of neuropathic pain. First line treatment is amitriptyline, duloxetine, gabapentin, or pregabalin. So, like that. If the initial treatment is not effective or is not tolerated, offer one of the remaining three drugs. So, can't give two of them together. Okay. Consider tramadol only if acute rescue therapy is needed, and consider capsaicin cream for localized neuropathic pain who wish to avoid or who cannot tolerate oral treatments. When withdrawing or switching treatment, taper the withdrawal regimen to take account of dosage and any other discontinued symptoms. Okay, medication overuse headache is one of the most common cause of chronic daily headache. It affects in 1 to 50 people. 1 in 50 people. Features can be present for 15 days or more per month. Develop or worsen while taking regular symptomatic medications. Patients using opioids and triptans are most at risk. Maybe psychiatric or comorbidity. Management is simple. Analgesics and triptans should be withdrawn abruptly. May initially worsen headaches. Opioid analgesics should be gradually withdrawn, like codeine. Okay, now headache following lumbar puncture. So it occurs in approximately 1/3 of the patients. The pathophysiology is unclear, but may relate to leak of CSF following dural puncture. Leak of CSF. Post-LP headaches are more common in female with a low BMI. So usually develops within 24 to 48 hours following LP, but may occur up to 1 week later. May last several days. Worsen with upright position, improves with recumbent position. Contributing factors are post-LP headache, increased needle size, direction of the bevel, not replacing the stylet, and increased number of LP attempts. Needle size, LP attempts, direction of bevel, not replacing stylet. Not contributing to the headache is increased volume of CSF removed or bed rest following procedure or fluid intake post procedure, opening pressure of CSF. All these things which may seem like to be affecting is not really position of patient. All these are not really contributing to the headache. So the needle size and the number of LP attempts, direction of the bevel, and not replacing the stylet are the contributing factors. Management can be supportive initially. Analgesia rest. If pain continues for more than 72 hours, then specific treatment is indicated to prevent subdural hematoma. Okay. And treatment options include epidural blood patch, epidural saline, and intravenous caffeine.